Good morning. Welcome to this session. I'm sure people will be coming in. We have an excellent panel today, and the organizers have been very kind today that we do have a few minutes at the end of the session for questions before the live workshop starts. So please think about the questions. And I'm very happy that I have two excellent co-chairpersons. And without further ado, I think we could get started with the first presentation. It says, Shifting Goalposts in Regional Anesthesia. And we have one of the main organizers, Dr. Gopal. So he doesn't need much introduction. Besides, it's all there. So welcome. Please go ahead, sir.
Respected chairpersons, members of the organizing committee, and dear delegates, a very good morning to all of you and welcome to this session. I hope we all have a wonderful conference and carry back pleasant memories from Pune. Over the next 20 minutes, I'll be speaking on shifting goalposts in regional anesthesia. I must disclose that I have received valuable inputs from Professor Vincent Chan in my literature search for this presentation. Unlike its more illustrious cousin, general anesthesia, the beginnings of regional anesthesia did not have a single eureka moment. Rather, the history of regional anesthesia was colorful and tumultuous and filled with daring self-experimentation by charismatic personalities. By the turn of the last century, the clinical and economic benefits of regional anesthesia were readily recognized, and comparisons began between RA and GA with regard to morbidity and mortality, and there were no clear-cut answers at that point of time. The brunt of adverse effects of poorly treated or untreated acute postoperative pain are borne by the cardiovascular system, and in respect of thoracic and abdominal surgeries, also by the respiratory system. Adverse effects also affect the gastrointestinal tract, endocrine, renal, hematological, and metabolic systems, whereas the psychological aftermath delays return to normal social preoperative function. As per the consensus guidelines of the ASRA and the American Pain Society, central to the concept of a multimodal analgesic regime is either a neuraxial or a peripheral nerve block. Though ultrasound as a guidance modality has been around for more than 2 decades, by 2010, it was being hailed as the unanimous gold standard for regional anesthesia, and that the search for the elusive Holy Grail had ended. Thanks to advances in ultrasound technology, today's images are not nearly as pixelated and present more information per unit area for the benefit of the viewer. And thanks to advances and an increased understanding of microarchitecture of nerves and surrounding tissues, we are enabled to be more selective with needle placement and deposition of injectate with respect to a neural structure. Increased awareness of local anesthetic systemic toxicity owes itself largely to intensive campaigns by ASRA and like-minded bodies across the globe. Today, instances of LAST, however rare, are suspected, diagnosed, and treated with lipolipid, thereby limiting the cardiac-related morbidity or mortality that can be attributed to a local anesthetic. Ultrasound-guided regional anesthesia engineered a paradigm shift from the deposition of local anesthetic in the vicinity of a nerve or plexus after visualizing the neural structure to deposition of large volumes of local anesthetic into interfacial tissue planes without actually having to visualize any neural structures. Today, we have a profusion of blocks to perform, and this generates a tremendous zeal amongst regional anesthesia enthusiasts to perform these blocks. And many a time, these blocks vary by the tiniest of margins or a thin interfacial layer, and these are often accompanied by a suitably clever acronym such as MTP or BRILMA or the SPANK. These three landmark papers in the year 2007 set off the trend in favor of interfacial plain blocks worldwide. And between 2011 and 2013, this man introduced chest wall blocks as a newer concept for analgesia following thoracic surgeries. And this paper in 2016 by Ferrero and colleagues literally caught the world of regional anesthesia by fire like no other paper in the recent past. And today, with just regard to the chest wall alone, we have a mind-boggling array of blocks to choose from. So we need to ask this question, are we having one block too many? And despite the fact that we have a basic understanding of the mechanism of action of most interfacial plain blocks, that of a paraspinal block such as erector spinae plain block is still in the realm of conjecture. And with the notable exception of a few, like the quadratus lumborum block, most of these blocks provide cutaneous analgesia alone, which means that they are not a standalone option for provision of surgical anesthesia. Rafael Blanco is here, and he will be giving his update later on during this session. One of the major limitations of peripheral nerve blocks, as we all know, is the finite duration of action of these blocks. And dealing with the aftermath of rebound pain is a challenge that remains to be addressed. The modes that we have to prolong the action of a block would be perineural adjuncts, liposomal local anesthetics, and perineural catheters. Virtually every single drug has been tried as a perineural adjunct, but amongst a huge list, it is only dexmedetomidine, dexamethasone, and buprenorphine that hold any promise going forward. And of all the drugs that are available, it is only adrenaline or epinephrine that has an FDA approval to be used as a perineural adjunct. We do know that liposomal local anesthetic drug formulations are structured in such a manner so as to gradually release the local anesthetic over an extended period of time, and with regard to liposomal bupivacaine, this is typically 72 hours. Very recently, a liposomal formulation of bupivacaine and meloxicam, which is a non-steroidal anti-inflammatory drug, obtained FDA approval for wound infiltration and intra-articular injections. Meloxicam, being a non-steroidal anti-inflammatory drug, is probably going to make things different when injecting in the surroundings of infected tissue. We also know that we have an array of perineural catheters that we can choose from. We typically use catheters through needles, either stimulating or non-stimulating, and today we also have catheters that go over the needle. But patronage of perineural catheters is limited because it requires additional technical expertise. There is the cost of catheter, pump, and running the infusions. There are complications with respect to insertion and maintenance. And we also know that when we place an interfascial plain catheter, a programmed intermittent bolus is called for to maintain the quality of analgesia. This is a fairly controversial topic, regional anesthesia and long-term consequences. So we just look at the long-term outcomes which regional anesthesia may affect. Now, acute pain, as we all know, is secondary to a noxious stimulus that is applied on the surgical field, beginning with the skin and allied structures. Acute pain responds to tissue damage. It is protective, adaptive, and self-limiting, and its evolutionary nature is to prevent behaviors that may impede or impair normal tissue recovery. Therefore, persistent post-surgical pain is something that persists beyond the normal duration of healing, which is typically not more than 8 weeks. And any analgesic regime that we may choose or design for the patient must be able to anticipate, prevent, and modify the nociceptive barrage, thereby limiting the pathological central sensitization. As I said just a while ago, pain during surgery is the result of a nociceptive input from the primary surgical site. This alters the synaptic strength, and therefore the signal transmission from the primary order neuron to the secondary order neuron is altered. And this pathological change can be blocked by local anesthetics by a variety of actions. One could be anti-inflammatory action. The second could be the prevention of ectopic firings of neurons, limiting cytokine expression, and also neutrophil priming. Can anesthetic technique influence cancer outcomes? The possibility of a causal link between your perioperative anesthetic technique and metastasis at a later stage following a curative surgery for cancer dates back to the publication of these two articles by Donald Buggy and colleagues in 2006 and 2008. Though this has generated tremendous interest, today we also have fellowships in oncoanesthesia, of which regional anesthesia is a central component. I must say that at this point of time, we do not have enough ironclad evidence to promote or recommend a particular anesthesia technique for curative surgeries of patients with cancers. So we look to answers from prospective RCTs, such as the volatile anesthesia and perioperative outcomes related to cancer, the VAPOR-C trial, which is a large multi-country, multi-center trial, which tends to compare sevoflurane versus Tiva with propofol, the beneficial effects of intravenous lignocaine in patients coming in for colorectal and lung cancer surgeries. GA Cares is another prospective RCT that is ongoing in the state of New York in patients who are coming in for 8 different cancer surgeries. And this trial typically compares Tiva with propofol and volatile inhalational anesthesia. So once these 2 prospective RCTs are completed, we will have certain answers which may lead to the recommendation of a particular perioperative anesthesia technique. We'll just look at a few new modalities in the offing. When patient-controlled analgesia came into being, it shifted the mode of analgesia from a scheduled mode to a requested mode, thereby making it patient autonomous. The patient had a role to play in choosing his or her analgesic at the time he or she wanted. If, for example, an artificial intelligence algorithm based on feedback from certain parameters can be built into existing PCA pumps, then the focus of providing analgesia will further shift from provision of salvage analgesia to that of preventive analgesia. And this can limit central sensitization further going forward. This is a work in progress. Hopefully, we will have it with us in the near future. And this was a recent publication in this month's RAPM by Bansui and colleagues. And this speaks about the role of neuromodulation in acute pain settings. As per the International Neuromodulation Society, neuromodulation is defined as the alteration of neural activity by the targeted delivery of a stimulus, either electrical or chemical, to specific neurological sites in the body. Typically, it is chronic pain settings which utilize electrical stimulation for provision of relief from chronic pain. But if we were to have a catheter for regional anesthesia, wherein in the first few days after surgery, we can provide a chemical stimulus by infusion of local anesthetics, and then move on to the provision of an electrical stimulus thereafter, intuitively speaking, the patient will have the best of both worlds. At this point of time, such catheters are frightfully expensive, and in time, we will probably have catheters that we can use for all our patients. And finally, we look at the challenge going forward. We need to ask ourselves this question: is regional anesthesia at a crossroads today? There seems to be an ever-widening gulf between regional anesthesia enthusiasts and general anesthesia enthusiasts, and the latter believe that the field of regional anesthesia is too complex and too intimidating. There are so many blocks that they need to keep track of and need to keep pace with. Therefore, at this point of time, there needs to be a change of perception from one of novelty to one of core acceptance. The broader question that we need to ask ourselves today is not whether we need more blocks, but how best to deal with the blocks that we already have. The basic blocks package, it aims at improving outcomes, efficiency, and acceptance while reducing disparity as far as the patients who will be receiving these blocks by a variety of anesthetists are concerned, is targeted at general anesthesia enthusiasts. And we must ensure, as regional anesthesia enthusiasts, that every single anesthetist can perform the blocks that form part of the basic blocks package. And we regional anesthesia enthusiasts can have a plan B, plan C, and plan D also, but then ensuring that everybody has a plan A is of paramount importance. And these are the core components to increasing patient access to regional anesthesia. So we select high-value nerve blocks. We ensure that there is widespread competence amongst our community, and then we ensure that we create certain protocols whereby the pathway is implemented in all patients. Different surgeries, as we know, have different pain trajectories. Yet, no two patients respond in a similar manner to pain, despite the pain generator and the surgery being the same in two different patients. Therefore, we anesthetists, for each patient, must design the right intervention at the right time for the right duration. And personalized pain management will depend on patient factors, surgical factors, the resources that we have at hand, while making an attempt to stick or adhere to AORA's principles. And finally, in conclusion, as regional anesthesia forays beyond the provision of acute pain relief alone into newer and newer domains, we must endeavor to distance ourselves from a complexity bias. Too many blocks for the few is not the dictum. The dictum should be a few blocks for the many, so that regional anesthesia becomes a core component of perioperative care for all patients coming in for all surgeries by all anesthetists. I thank you for your attention. I look forward to your august presence and robust participation next August in Hyderabad. Thank you, sir. Thank you.